Welcome back to our series. Our team is grateful you're here. A couple of updates for you. You can find our updated programming in a new newsletter on the web. Just Google Greenberg Bladder Cancer Institute. Next month, on May 25th, we'll be hosting our final session of this spring semester before a summer respite. We will be welcoming Dr. Amin Haradi to talk more in depth about sexual health. And I wanted to draw again your attention to our evolving group of programs specifically tailored around the experiences of women with bladder cancer, developed by Doctors Armin Smith and Jeannie Hoffman-Sensis, and the program team of Pamela Getz, Samantha Rockler, and Stephanie Cooper Greenberg. As Elizabeth Platts reviewed with us earlier this spring, exercise is important. So I wanted to personally encourage all of you to consider joining our virtual team for the Bladder Cancer Advocacy Network's Walk to End Bladder Cancer, being held on Saturday, May 1st. Google Beacon, that's B-C-E-A-N, and you'll find our team there, Greenberg Bladder Cancer Institute. Appreciate your support of the important work of our partners at Beacon. Again, all of these are up on our site, and if we can help you directly, we're only an email away at bladdercancer, all one word, at jhmi.edu. I'm grateful to all of you for joining us today for a conversation with Dr. Glenn Treisman. I hope you allow me the chance to give him a brief introduction. He's the Eugene Meyer II Professor of Psychiatry and Medicine here at Hopkins. He attended the University of Michigan Medical School and came here for residency in 1991. He's the director of the AIDS Psychiatry Service, the Pain Treatment Program, and his most recent effort as co-director of the Amos Center, a program that studies atypical gastrointestinal disorders and the relationships between food, the nervous system of the GI tract, microbiome, and disease. His work in the field of HIV, where many have described him as the father of AIDS psychiatry, has been groundbreaking and has raised the awareness of the role of mental illness as a driving force in the HIV epidemic, as well as a barrier to effective care. In the pain treatment space, he's built a novel interdisciplinary team, modeled for other centers, including our own, which seeks to manage the complex medical and psychiatric illnesses for the untreated or undertreated patients with combinations of addiction, chronic pain, dementia, HIV, AIDS, hepatitis C, GI disorders, autoimmune disease, and chronic mental illness. He's trained and mentored a generation of providers here at Hopkins. And when speaking colleagues recently about Dr. Treisman joining us, their reactions were all clustered in a similar space and quite simple. He cares about getting people better and works tirelessly to help them, no matter who they are, what they may be struggling with, or where they come from. Glenn, thanks very much for joining us, and I look forward to your presentation.
David, that is awfully nice of you that introduction is way more generous than I deserve. I really do appreciate this opportunity to talk to you about bladder cancer and depression. My career has been a complex exploration of, did I share my screen? I didn't. My career has been a complex exploration of the relationship between medical disorders and psychiatric disorders. And bladder cancer is a great example of that. So I thought it'd be a fun talk to give. I have no current conflicts of interest regarding this material. And today I'd like to talk to you about the clinical syndrome and symptom that we call depression, the biological underpinnings of that condition, and discuss the diagnosis and treatment of depression in bladder cancer patients. When I start with a case, this is just a coincidental case that I had very recently. 78-year-old athletic coach in good physical shape, still coaching, and was referred to me for episodes of depression starting approximately 8 years ago and getting worse with each episode. His complaint was he cannot sleep, wakes up early in the morning, can't fall back asleep, weight loss about 20 pounds, severe anxiety, stays up at night worrying about money, which is something his wife says they don't have a lot of money, but they don't have to worry about it. Loss of libido and some suicidal thoughts. I began treating him, and it took 6 months to get him better. He ultimately got substantially better on a 5-drug regimen, but as part of his workup, we sent for a urine analysis, and he had a few red blood cells. And you heard that noise of the shark in the water, and sure enough, he had non-invasive bladder cancer. What was quite remarkable is after his bladder cancer was treated, his mood improved considerably more. And we were able to get rid of at least 1 or 2 of his medicines. I think he's only on 3 drugs now. So this is a guy who said, if I could feel like this for the rest of my life, I'd be very happy. He's had recurrence a couple of times of his bladder cancer, but continues to do remarkably well. So what is the relationship between depression and cancer? Well, one of the things you need to know is depression makes people smoke, makes people drink, puts people at risk for all kinds of things that are risk factors for cancer that we tend not to think about. For instance, we tend not to think about the impulsivity of people with depression. Depressed people, although they have less sex, when they have sex, it's more impulsive and often more high risk. So that's one of the risk factors for getting HIV, but it's also a risk factor for getting other STDs that can lead to cancer. Impoverished people are much less likely to come to the doctor. They tend to be hopeless. They have substance abuse issues that depression provokes, cognitive impairment and disenfranchisement, which can hide cancers, and then a pro-inflammatory state that a few people have demonstrated. Depressed people are probably, although inflammation provokes depression, depression probably puts you in a pro-inflammatory state. And then stress and sympathetic overactivation. These are all risk factors for oncogenesis, but then cancer itself can disenfranchise people, demoralize them. It's associated with substance use. Bladder cancer is associated with 50% of patients with a mental illness, and of those, the bulk of them are substance abuse increases. Subcortical injury, some cancers cause cognitive impairment, inflammation, stress, and sympathetic overactivation, which make depression worse. So this cycle of cancer increasing your risk for depression, depression increasing your risk for cancer, and each disorder making the other worse are part of what drive the relationship between these two things. Major depression is a very common disorder. Most people think it's about 4% of the world's population. Depression is the single largest contributor to non-fatal health loss. 7.5% of all years lived with disability. In 2015, almost 1 million people committed suicide. Suicide accounted for 1.5% of all deaths worldwide, and is in the top 20 leading causes of death. Depression is right up there. So depression demoralizes people, makes them hopeless, but it also leads to suicide, disability, and poor health outcomes. The biggest diagnostic issue we face is that the assumption when someone comes depressed is that their depression is provoked by their life circumstances. None of us tend to think that if our femur is broken, it was caused by something that happened in our personal lives, unless it was an accident. But when you're depressed, you assign it a meaningful event in your life. I broke up with my girlfriend. My girlfriend broke up with me. My career is not going well. Any number of other things. And the problem is often the girlfriend breakup and the career not going well are caused by the depression, not the other way. So the problem is that depression is a symptom, and we tend to diagnose major depression, the disease kind, using symptom checklists, which are very reliable, but are not very valid. That is, a lot of people will give you the symptom checklist for depression because they're depressed, but they don't have depression. They're depressed because of what's going on in their life. Other people will not diagnose because they'll write off their symptoms as being caused by their life, and their checklist won't make criteria even though they have the condition. These are the DSM-5 core criteria for depression. Depressed most of the time. Well, what do we mean by depressed? Do we mean sad? Do we mean flat? I think the second one is the most important one, and this is the one I tend to stress. Markedly diminished interest or pleasure in all or almost all activities, significant weight loss or gain, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue, loss of energy, feelings of worthlessness or excessive or inappropriate guilt. Self-blame is one of the big parts of depression. Diminished ability to think or concentrate, and recurrent thoughts of death or suicide. These are all things that the DSM has emphasized, and they probably all belong on the list. The problem is they have to be seen in the context of your individual patient. And these criteria tend to be used as a checklist when they have to be used in the context of knowing the case. These are models of depression that people have talked about. There's the dopamine deficit model and the serotonin deficit model. The people who are on the serotonin side have probably much increased anxiety and depression and compulsive behaviors and OCD-like symptoms. But they also tend to have aggression and suicide as part of their syndrome. The dopamine deficit decreases drive, pleasure, and causes kind of a flattened apathetic state or anergic state. I think the core feature is more of a dopamine deficit than a serotonin deficit, but this is argued about a great deal, and clearly these two things have a great deal of interaction between them. So decreased dopamine gives you loss of rewards, and the loss of rewards can make you sad, but it can also make you anxious, apathetic, or irritable, depending on the kind of person you are. If the reason you get out of bed every morning is to get your dopamine, when you don't have any dopamine, you're likely to be apathetic. If you feel like something's wrong with you and you're not living up to your part of the bargain, you'll get anxious. If nothing feels good, you can get sad. But some people, when they're not getting rewards from things, they get cranky. So you see manifestations of all four of these kind of core features in people with depression. So as you go through the literature, you're going to find depression and anxiety lumped together often. That's because the condition major depression produces a lot of anxiety. Depression has been shown in the general population to increase morbidity and mortality from all kinds of things, including cancer. In diabetes, post-MI, congestive heart failure, post-stroke, and nursing home patients, you see fairly substantial increases in both morbidity and mortality related to having major depression, especially if it's untreated. This is cumulative mortality in patients with and without depression after heart attack, very famous study, 2001 study, and similarly, a stroke mortality study. We in the HIV clinic showed major depression is associated with decreased survival, and intervention with antidepressants changes that. Other people have had trouble showing interventions with antidepressants improving outcome. Factors that are associated with developing major depression include CNS inflammation. The question is, what about peripheral inflammation? And we don't know the answer to that, but I can tell you that it appears that conditions like multiple sclerosis have very high rates of major depression, whereas Lou Gehrig's disease, much lower. So CNS inflammation, autoimmune disorders are very highly related to major depression. Substance abuse, this is a condition that runs in families and there's a genetic vulnerability. Subcortical damage, if you have a stroke in the subcortical regions of your brain, Parkinson's, Huntington's disease, you're very likely to develop major depression. Chronic illness and stress, which are associated with increased rates of major depression. And this is a complex set of comorbidities. So when you think about the drugs we give for cancer, the drugs we give for HIV, the drugs we give for lots of our medical conditions, a great number of them provoke or worsen depression. Brain inflammation and injury increase depression, and immune dysregulation increases depression. But then depression itself increases disability and social isolation, substance abuse, impoverishment, risk behaviors, and poor adherence. And these things go on to decrease your ability to take care of the medical problem that provoked the depression in the first place. I want to make the point that there are really two kinds of depression we talk about. There's the kind that used to be called demoralization. I still like that word, demoralization. This is sometimes called reactive depression or grief or adjustment disorder. The term adjustment disorder seems seems less satisfying to me than demoralization, but it is right now the preferred term. And people with demoralization generally are distractible from their loss or for their grief. They have more initial insomnia than terminal insomnia. They have no necessary family history. Episodes tend to be unique. There's a stable life course, and they're responsive to positive events. And all of this in this audience, everybody listening, has had this condition, demoralization, where you say, I'm depressed because of a romantic disappointment, a job disappointment, any number of other things that demoralize you and make you feel like giving up and somewhat hopeless. But we respond to demoralization with time, support from our friends, encouragement. Over here, I have major depression, the disease kind, and this is a dopamine dysfunction condition. It produces anhedonia, a pervasive loss of rewards from any activity, more AM insomnia than initial insomnia. Patients wake up early in the morning, can't go back to sleep, tends to run in families. Patients have often had similar episodes earlier in their life. It produces a disrupted life course, so people will look like they're doing well for a while, have trouble, then get back on track, and then have trouble again. And it tends to be unresponsive to positive events. So you notice I have these two circles overlapping. People can be demoralized, have stress from the demoralization, and trigger an episode of major depression. People with major depression can have losses because they're depressed that demoralize them further. So these conditions aren't independent of each other, and sorting out how much is demoralization, how much is major depression can be very difficult. It is particularly difficult in oncology, where patients have a good reason to be demoralized. So I'll tell you about two cases I saw 2 weeks apart on the consult service. Both patients had lymphoma. One guy had relapsed lymphoma several times, and he was sitting there, and his family was visiting him, and he said, I know if I could just get out of the hospital, I would be fine. I just can't wait to get out of here. But I'm so depressed by being stuck in the hospital. My family has to drag themselves down here to visit me. And if it's going to relapse over and over again, I wonder if it's all worth it. He was sitting there with his little grandkid in his lap. And the other patient was sitting in a darkened room with lymphoma. And he said, if I go home, I'll just be miserable at home. There's no point in any of this. And all I think about is how to get out of here with the most comfortable route. And one guy was demoralized, but ready to go with his life. And the other guy has major depression. And patients with major depression are pervasively anhedonic, whereas demoralized patients, when their little grandkid gets put up in their lap, they usually brighten up a lot. My guy, by the way, with major depression said, I wish my family wouldn't visit me because, it's hard on all of us and I don't see any point in it. So you have to think critically when you're making a diagnosis of demoralization versus major depression. And we tend to underdiagnose major depression and overdiagnose demoralization in our patients. Demoralization probably doesn't respond to antidepressants, does respond to psychotherapy, and psychotherapy has been shown to improve quality of life and outcomes. Psychotherapy is a really good thing for people who are demoralized. And it's hard to get it when you have cancer, but it is something that really helps patients. The problem with the diagnosis of major depression is that it's stigmatizing. Nobody wants to be told they have major depression. Nobody wants to have a mental illness, least of all physicians. There's a cultural rejection of mental illness across most cultures. Everyone interprets their illness as being stress-related, and patients would rather believe that they're bad or that they're medically sick than believe that they're mentally ill. And they resist the idea that they have a mood disorder very significantly. I had one patient who said, I'd rather have cancer than major depression. And I said, well, you have both, and we can treat both. This is a quote from one of my patients in the HIV clinic. "I'm not depressed. If I am depressed, people keep telling me I'm depressed. There's nothing more depressing than being told you are depressed." And patients are quite stigmatized by this. There's an international study published in New England Journal in 1999. Patients presenting with somatic symptoms shown in blue, patients presenting with psychological symptoms shown in orange. These are people coming with major depression. And you can see most of them come with somatic complaints rather than psychological complaints. You have to really push them to find out about the depression. This is a study that is very obvious to everybody, and this was published from Kaiser Permanente HMO patients. And this is an old study, 1997. I like to show this study because the most important part of it is missed by a lot of people. So this is Sheehan Disability Score. This is missed work, and this is marital distress in people with no depression, depression, and depression and a second illness like cardiovascular disease. Disability score higher when you have depression, higher still when you have a medical problem. Missed work, higher with depression, higher still when you have two problems. Marital distress, much higher when you have major depression, but when you have a second medical problem, the marital distress goes down. Wives and husbands understand cardiovascular disease. They don't understand major depression. They don't sympathize with patients with major depression, people with major depression, because they think if you just pull yourself together, everything will be okay. People who have never had a mood disorder, never had a depressive disorder, have real trouble sympathizing with people who are having one. Because to them, it just seems like if you just pull yourself together, everything would be okay. So one of the questions is this a biological disorder or is it all demoralization? This is some work done by a variety of people, but one of them is Robert Sapolsky here, who's I think one of the great neurological researchers around. He's a primatologist who did a lot of field work on baboons at Stanford, but he's also a great critical thinker about our field. And if you stress people, you get increased glucocorticoids and decreased brain-derived neurotrophic factor, and you actually have atrophy and death of neurons, which you can show. And when you reverse this, you have increase in growth and survival of neurons. So these don't occur everywhere in your brain, but a couple of places there are neurons that are constantly turning over. And we tend not to think about them too much, but the turnover in neurons is important in depression. This is a study in molecular psychiatry. Controls, this is one of these rendered drawings. Controls with lots of neurons. Stress reduces the number of neurons, added antidepressants, and the neurons come back. How do we see these things in animal? This is a mousie, and he's part of the sucrose preference test. Mousies who are well will work hard to get sugar water. They like sugar water. Mousies that are depressed don't care too much and like this mousie, just seem apathetic about the whole thing. This is a mousie on the elevated plus maze. Normal mice will go out and explore these kind of scary looking protrusions out into the middle of nowhere. Depressed mice tend to stay in the closed areas that are more safe. And this is the 4 swim test. This is a rat in the swim test. If you throw him in this jar, swims like crazy, swims like crazy, swims like crazy. He can't get out, but he doesn't want to give up. Depressed mice give up. Depressed mice and rats give up fairly quickly in this test. They just float and don't try to get out of the jar anymore. So, how do we think about diagnosis? Well, one of the ways you can make a diagnosis is you can have years and years of experience taking care of patients, understanding the subtleties of major depression. And the other way is much easier. You can use a checklist. So back when we were doing the epidemiological catchment area study, this is a long time ago, Baltimore was one of the areas, one of the sites, we found a major depression prevalence of 4 to 6%. That's been the number in many epidemiological studies, rural, urban, all over the world, Far East, Near East, Western Europe, here, almost every place has numbers very similar to this. Iceland is an exception. And schizophrenia, 1.3%. Come along, National Comorbidity Survey, 15 years later, 20 years later, schizophrenia, the same number. But look, there's been a fourfold increase in depression. And that's because this study used a much more elaborate diagnostic rubric than this checklist survey. And you miss lots of depression, but you also overcall lots of depression using checklists. And what that's led to is a lot of noise in our understanding of depression. So if you look at the Cochrane Review of Treatment of Cancer Depression with Antidepressants, it's a very disappointing review, and they kind of give the idea there's no point in giving people antidepressants. This is a study from PLS Medicine, 2008. This is a meta-analysis of nearly all the antidepressant trials up to that point. This is initial severity in terms of the Hamilton rating scale, and this is improvement with drugs, drug in blue, placebo in yellow. What you see is, till you're really sick with depression, there's no statistically significant difference between drugs and placebo. And this came out, got republished in JAMA, and everybody was talking about it in the Wall Street Journal, had articles about how the antidepressants don't really work. And I had patients come in and ask me how I could give them these medicines when this study shows antidepressants don't work. That's not what they showed. What they showed is best exemplified by this study published in 2002 in JAMA. This is all antidepressant trials between 1980 and 2000, looking at placebo, tricyclics, and SSRIs. SSRIs in yellow, tricyclics in purple, and placebo in blue. And what you can see is at 40% in 1980, up to 60% in 2000, and the placebo response is 20% in 1980 and goes up to 40%. Well, out here, the error bars overlap enormously. And what's happening is between 1980 and 2000, more and more of the studies are being done outside of academic centers in private practices, and more of the recruitment is being done using checklists for depression, and you're getting more and more noise. And so the placebo response in this study was, the increased placebo response was attributed to the idea that people knew antidepressants worked. That's not really what happened at all. What really happened is, over time, we've included in a lot of our studies people who are depressed but don't have the condition major depression. And on a checklist, you can be considered depressed fairly easily. So let's talk for a minute about bladder cancer. Bladder cancer is the 9th most common cancer in the world. The most common presentation is hematuria. Neurological symptoms are considered uncommon, but our knowledge about neurological symptoms related to paraneoplastic syndromes in bladder cancer is very limited. And the in general, paraneoplastic syndromes are thought to be developed because of autoimmunity and due to antigens released from tumor cells and the immune system's response to tumor cells. Onconeural antibodies could affect central nervous system. So there's been a number of studies showing, looking at and showing these onconeural antibodies causing a variety of neurological problems. The problem is they haven't been very well demonstrated in depression. And depression probably is more complicated than simple onconeural antibodies. Probably has more to do with cytokines and the general inflammatory status. So cancers provoke an immune response, and transmitters like IL-6 been shown to be very involved in major depression and are provoked by some cancers. So these are nervous system paraneoplastic conditions reported with bladder cancer. I didn't list the ones that aren't reported with, that are bladder cancer related paraneoplastic syndromes that are not CNS linked, just the ones that are. There are others, but this is the majority of them. There are 4 cases of cerebellar degeneration in bladder cancer, cases of transverse myelitis, diffuse encephalopathy, Isaac syndrome, neuromyotonia, retinopathy. There's a bunch of cases that have been reported. Thromboembolic stroke due to clotting. This is probably not strictly a CNS paraneoplastic syndrome, but many of these patients present, their embolic strokes present as a CNS problem. Neuronopathies and polymyalgia rheumatica. I mentioned polymyalgia rheumatica because that's how my cancer presented. Uveal melanocytic proliferation in the eye, sensory neuropathies, priapism, usually leukemoid priapism, but you can see other reasons for it. And then all kinds of parathyroid related conditions, because if you remember the hyperparathyroid things, stones, bones, abdominal groans, and psychic moans. And people with hypercalcemia get depressed and have lots of psychiatric symptoms. And then myasthenia. So bladder cancer presents in a variety of ways. Often the depression precedes the diagnosis of bladder cancer. In many of the conditions that patients that I follow for a long time, their cancer shows up much later. So they had a lot of patients who developed over time lymphomas and other bone marrow cancers who had depression for years that was hard to treat and resistant and turned out to be paraneoplastic, at least in part. The studies of bladder cancer and depression range from 6% to 78%. That is not a reflection on oncologists, that is a reflection on the poorness of our ability to really think critically about how we make a diagnosis of major depression and to survey our patients. It's clearly less prevalent in patients with non-invasive disease. More aggressive treatment probably reduces depression. So curative treatment or very aggressive treatment probably reduces the inflammatory response and reduces rates of major depression. So this is a study of patients with non-invasive bladder cancer looking at an SF-36 mental health component survey. And if you just do transurethral surgery, you see that they don't get nearly as much better as if you add BCG or mitomycin C. So the improvement over 6 months and 12 months in patients who are treated in terms of mood is much more prevalent, much more obvious in patients who are treated with something other than just surgery. Does this mean that there's residual microscopic cancer that's causing the ongoing depression? That would be my interpretation of what's going on, but we don't know the answer yet, and it's an area of exciting research, I think. This is patients looking at perioperative distress, essentially a way of looking at depression. And what you see is preoperatively high rates of depression, 42%, postoperatively down to 29%, anxiety, 55%, postoperatively 29%, somatization stays the same, and general distress goes down as related to the depression and anxiety. And I think what's happening is these are people whose depressive subscales are going down because of resection of their tumors. This is psychiatric illness in people with bladder cancer and survival. And basically what this shows you is over time, the longer you survive, the incidence of psychiatric disorders actually goes up. And I think this is going to be driven in large part, eventually we'll figure out that a lot of this is paraneoplastic. It's attributed right now to the stress of living with bladder cancer and to the distress related to the uncertainty of your condition. But lots of medical conditions have uncertainty, and don't get up to 50% comorbidity of major depression. More importantly, if you look at patients who have major depression and present with what I will call psychosomatic complaints, I recently saw one of our colleagues whose family member had a terror of having lost hair. Her hair was falling out. And this was a manifestation of major depression. But she was totally focused on her hair. And in the same way, you can get totally focused on your cancer, or totally focused on your uncertainty if you have ongoing depression. And I think we tend to over-identify with our patients in the sense of saying, well, if I had bladder cancer, I'd be depressed too, without thinking critically about, well, maybe if you had IL-6 levels, you'd have depression too. This is a Kaplan-Meier survival curve looking at telomere length and depression in patients and survival. And what you see is if you have depression, you're less likely to survive. And if you have shortened telomeres, you're less likely to survive. So stress clearly makes things worse, and depression makes things worse. And the combination is worst of all. The other side of it is if you have psychiatric disorders, you're less likely to survive. And the odds ratio of cancer survival, the hazard ratio is 2.2-ish for these patients with 3 psychiatric diagnoses. And with only 2, there's an increase in hazard ratio that's significant, but is hard to pin down. So we tend to think about life events, genes, systemic illness, and brain injury causing depression. But we also have to think about the way depression affects those conditions. So one of the most remarkable studies that I've been involved with, one of my postdocs and I did a study where we looked at HIV virus in brains of people who had undetectable peripheral blood. So they had no virus in their blood. They were on triple therapy. And we looked at the relationship between depression and small amounts of virus in their brain, assuming that chronic inflammation would cause turnover of cells that had a residual virus in them. And you'd see a little bit in their CSF, not enough to be infectious in any way, but enough to provoke a depressive response. And sure enough, the more virus you have over time in your brain in this study, the more likely you are to develop major depression. Now, I said there's no point looking at the reverse, but he did. And what was remarkable was the longer you are depressed, the more likely you are to develop small amounts of CSF virus, because depression is a pro-inflammatory state and will provoke ongoing turnover of HIV particles. So depression is causing trouble for us in causing chronic inflammation, as well as being caused by chronic inflammation. When you start talking about treatment of depression, you have to think at least a little bit about diagnosis, because I think accurate diagnosis is critical. Most patients are underdosed. Most patients stop treatment too soon. Most patients are treated to improvement and not remission. Most patients don't get adequate effort to optimize their therapy. And the internet is not an adequate substitute for medical school. So I have many patients who come to me and have done a great deal of internet research on how nonsensical everything I'm telling them is. And when it comes from a doctor, it's particularly irksome. So I had a thoracic surgeon tell me he'd looked up his condition. I said, if I went to the internet, do you think I could learn to do thoracic surgery? No. Well, give me a break. So this is my one slide discussion of antidepressant therapy. So the drugs on the left here, tricyclic antidepressants, the hardest drugs to use. You have to get blood levels. You have to think about toxicity. However, these drugs work. And when other drugs haven't, you have to at least think about these. Levels are useful, so you know if a person's on a therapeutic dose. These drugs are good for sleep. They're antihistaminic. They promote appetite. They're good for chronic pain. They're great for migraine. They slow your gut down, decrease the likelihood of diarrhea, and they downregulate the sympathetic nervous system a little bit. So if people have chronic sympathetic overactivation, they can be very useful for that. SSRIs are very easy to use. You don't have to get levels. They're safe in overdose. We tend to underdiagnose them because undertreat people because when these drugs came on the market, the big thing was to not have any side effects. So they tend to be underdosed in the trials. They're good for anti-anxiety effects in OCD. Here they are. The one I use the least is paroxetine because it's slightly anticholinergic, slightly antihistaminic, good for sleep and causes weight gain. But these other drugs, you can add something good for sleep that causes weight gain and take it away. Whereas when people get better, you're stuck with this. The shorter half-life drugs like paroxetine also can cause some withdrawal or discontinuation syndrome when you go off them. There are two new drugs, vilazodone and vortioxetine. Maybe they fit into this category, maybe they are their own category. Sorry, this is my allergy to my cat. SNRIs, a newer class of agents. These are very easy to use, also safe in overdose. You don't have to get levels. These are good for pain and migraine, and they have some noradrenergic reuptake inhibition, good for people with sympathetic activation. And then over here, we have these atypical drugs. I'm going to point out one to you, I think is the most important one for oncologists to think about, and that's mirtazapine. It was marketed as Remeron. It's available in a soluble tab, so you don't have to swallow it. It causes weight gain. It causes good sleep. It has very few side effects in most people. Most patients tolerate it very well. And the problem is of the weight gain in many patients is a big problem. I won't spend any time talking about these more arcane drugs, ketamine, psilocybin, dextromethorphan, and allopurinol, except to say that keep your eye on them. Monoamine oxidase inhibitors, you're unlikely to ever use them, but you should know they're out there. And then a huge number of things that we can do to augment depression if people don't get better on our first or second choice of drugs. I use these drugs a lot for oncologists. I like to point out testosterone and estrogen. In some people, loss of estrogen and loss of testosterone, can exacerbate depression. And you have to at least think about physiological testosterone and estrogen replacement in people with refractory depression. We tend not to think about it, but it's important for some people. And there's the usual conversation about dietary changes, exercise, the importance of sleep hygiene, and then neuromodulation, like vagal nerve stimulation, deep brain stimulation. And these things can be very important in really refractory depression. One of the things that I emphasize is a healthy diet. Nutrition tends to be under considered in patients with depression, and just omega-3 fatty acids can be very helpful for patients, and a variety of other things. Last point I would like to make is that patients with depression tend to want to give up. They tend to want to give up early. They tend to be ready to go to hospice even if they don't have cancer, and they're pessimistic about a treatment, and we have to recognize that that can be a complication in treating them. So this is a study done by Emmanuel in 1996, a survey given to 155 patients with cancer, 355 oncologists, and 193 people from the public using demographic matching by using the first three numbers of their telephone number to try to match them. And they gave people 4 scenarios: unremitting pain, burden on family, functional disability, and life is meaningless, and asked them if they would consider euthanasia or assisted suicide for any of these conditions. Now, the doctors didn't see much difference between euthanasia and, the patients didn't see any difference between euthanasia-assisted suicide. The doctors did, but the patients didn't. And they gave nearly identical answers on euthanasia and assisted suicide. So 23% of the time, doctors thought unremitting pain was a reason for assisted suicide. Patients, 68%, 66% of the public. Burden on family, 15% of doctors, 50% of patients, 50% of the public. Functional disability, 6% of doctors, but a third of patients in the public. And life is meaningless, similar numbers. However, if you looked at patients who had chronic pain, were over 50, were religious or Catholic, or relapsed, they were much less likely to endorse these things. And 20% of patients and 27% of the public said they would change doctors if they found their doctor had ever provided either euthanasia or assisted suicide. And pain and relapse made this more likely as well. So this is another part of the survey. Assisted suicide and euthanasia. People who considered requesting it, 27% of the patients with cancer diagnoses, 32% of the public without a cancer diagnosis. Oops, sorry. Discussed with their doctor or family, 12% of patients with cancer, 16% of people without cancer. Oncologists said that 38% of them said they'd received the request for euthanasia, 51% said they'd received the request for assisted suicide. And then on the phone, on a survey, 2% of oncologists said they had provided euthanasia, or 20% said they'd provided assisted suicide at a time when it was illegal. If people call you on the phone and say, have you killed your patients? Please say no. The take-home message that in this paper was that patients who seriously considered and prepared for euthanasia-assisted suicide were more likely to be depressed, and they were not inclined to euthanasia or assisted suicide if they had chronic pain, the people who sort of this was targeted at. This is their statement. The interventions, those are my quotes, were approved for terminally ill patients with unremitting pain. But these are not the patients most likely to request such interventions. And this is a big issue to think about. We have to think about this concept that is missed a lot in medicine of impaired autonomy. So in my world of HIV and drug addiction and chronic pain patients, there's a huge amount of impaired autonomy. People want to think their ideas are autonomous or their decisions are autonomous, but they're not the decisions of an autonomous person. So it's important to think about the frequency with which patients with one kind of cancer who have no more pain than another kind of cancer request assisted suicide or want to go to hospice, and whether or not those people are depressed and should be encouraged to have treatment. Because I think we miss people with impaired autonomy, and depression impairs autonomy. This says, ask your doctor if taking a pill to solve all your problems is right for you. I don't want you to think I'm oversimplifying. There are conditions other than major depression that we have to think about. And it's incredibly important to think about life story problems and the things people are living through, and think about psychotherapy and personality vulnerabilities and substance abuse issues where a pill might not be the right intervention. But we tend to undertreat, underdiagnose major depression. Our patients aren't getting enough treatment. And in oncology, their resources seem very scarce in terms of getting patients decent psychiatric evaluations. One of the problems in the rest of my world is that patients, when they're sent to a psychiatrist, think their doctor thinks their problem is all in their head. When I see patients with oncology problems, at least they don't think they're being referred to a psychiatrist because they don't really have something biologic. Nonetheless, they often resent the referral to a psychiatrist as if it's somehow an indictment of them not handling their illness well, when what's really going on is their oncologist wants them to have a better course and knows that they're less likely to do well if they have untreated major depression. I think I'm going to stop there and take questions, but I want to thank you for inviting me. I hope this was useful to you and fun for you. It was certainly a pleasure for me to come and talk to you about our patients.
Glenn, thanks so much. We've already got some questions coming in. Invite you out in the audience. If you've got a question, go ahead and put it in the Q&A. This is from Pat Kasdan. Can you tell if depression is provoked by medication or not?
Sometimes you can and sometimes you can't. So if you have a patient who is 22-year-old with poison ivy, has never had a depressive symptom in his life, and you put him on steroids, and 2 days later he hangs himself in his bedroom and pulls the lamp down, I think you can really say that the steroid did it, especially if when you stop the steroid, it goes away. So having seen that case, I can just tell you that sometimes you can really tell if the medication provoked depression. Other times it's much tougher. But there are medications that are clearly more associated with the development of mood changes and depression than others. Steroids, sex steroids particularly, lots of chemotherapeutic agents, anything that's neurotoxic, things that affect immune activation or immune activity can cause depression. We see a huge amount of that in my collaborative work with people in rheumatology and autoimmune disease, and then a variety of other things. So weirdly enough, ciprofloxacin causes depression in some people, much less so levofloxacin, which also causes depression in some people, and other floxins less. So I can't tell you why, but I can tell you it's reliable. Non-nucleoside reverse transcriptase inhibitors of the generation when I was doing a lot of HIV work clearly caused depression in patients. It's an endless argument at meetings. I fought about it. As soon as those drugs went generic, they became much less popular in terms of trying to convince everybody that they didn't cause CNS side effects. So it can be very tough to tell. And remember, you're dealing with a group of patients who have other reasons, especially in oncology, who have other reasons to develop a de novo affective disorder. So their major depression may be related to their cancer, may be related to weight loss and cachexia, may be related to a paraneoplastic issue, may be related to loss of underpinnings, may be related to stress. But for some drugs, it's pretty obvious. And the animal models are pretty good. So there's this cool animal model. Somebody noticed that the population of people who eat beef jerky have increased rates of mania. And in laboratory animals where you can produce bipolar disorder, where you can produce mania in the rats, beef jerky will reliably provoke them into a manic state. So, it's really interesting because we don't tend to think about these things. And the complexity of us as organisms is really remarkable. Butyrate probably has antidepressant effects, the short-chain fatty acid, and there are clearly psychiatric effects of toxoplasmosis. We tend not to think about them because they're insisted in your brain and you don't feel like they're doing anything, but they probably are doing things. And so, how much of you is you, and how much of you is your GI microbiome? And it's a good question.
A lot of us interested in that here, that's for sure. So Eric Mailman has a question I'm going to expand upon just a little bit. He's asking, is bladder cancer more likely to result in depression than other cancers? And I would enlarge that to ask, do you think there's a correlation between the cancers that respond to immunotherapy and autoimmune disease and depression?
Great question. So I think bladder cancer is less likely to cause depression than most cancers. I think pancreatic cancer causes the most depression of anything I've seen in terms of oncology. Those patients are very hard to get better. I do get them better, but it requires really flogging them. And the cancer I've diagnosed most as a psychiatrist is pancreatic cancer in these refractory patients. So I think there is a big difference. I think bladder cancer is on the low end. You see more paraneoplastic stuff with small cell bladder cancer, whatever you want to call that weird condition, the neuroendocrine bladder cancer, oat cell bladder cancer is the way I learned it when I was going to medical school before time began. But so I think there is a big difference. I think that immunologically active cancers produce more paraneoplastic depression. I think that limbic encephalitis is underappreciated and is associated with depression. And there are autoantibodies that we've associated specifically with depression and other psychiatric conditions. But having said that, bladder cancer probably is not one of the worst offenders, but it certainly looks like I surveyed a lot of literature that I haven't looked at in a long time about bladder cancer for today's talk. And it's all over the map, just like it is in HIV, by the way. I come down for HIV on the number 30% of patients with HIV have a provoked affective disorder because of the virus. My guess is in bladder cancer, the number's probably 2 or 3 times background, if not higher. But it's probably not nearly as high as pancreatic cancer, which is 5 to 10 times background.
Excellent. So my friend Stephen Williams is joining us from the University of Texas Medical Branch, and he says, thanks for the excellent discussion. Our group at UTMB showed up to 50% incident psych diagnosis following treatment for muscle-invasive bladder cancer. Follow-up studies showed decreased adherence with only 1/3 patients continuing prior psych meds. We need more research in this area, and how can we increase adherence in our bladder cancer patients with prior psych history?
Well, the weather today wouldn't do it, but over the winter, I would have said you can invite me down there. Yeah, so adherence is a really interesting thing. The thing that works in the HIV clinic is a personal relationship with patients. And there is a more complex rubric or matrix of psychiatric problems. So patients can have depression and be very adherent. Other patients are less adherent. That often goes down to personality and temperament of people. People who tend not to be compliant with anything aren't going to be compliant with your medicines. But trying to figure out what the barriers are for adherence in an individual patient is a productive exercise. Telling people to not let their feelings run their life, very productive exercise. Terrifying some people into taking their medicines, a productive exercise. I have patients in the HIV clinic who would say, well, I'm just going to die. And I would pull out that big dermatological atlas of horrible stuff that happens to you from HIV and say, you're going to die, but first, these things. That can be very, very helpful in getting people to take their medicine. They think that Tuesday they'll just go to sleep and not wake up if they don't take their bladder cancer treatment. That's not what's going to happen. And so you have to try to figure out what motivates people. We as physicians tend to be consequence averse. We tend to avoid consequences. So if I have a doctor who's a patient and I'm trying to get them to do something, I just show them some horrible consequence of not doing it, and they do it. With patients who are often extroverts, the problem is they're reward seeking and reward driven, and there is nothing rewarding about taking their bladder cancer medicines, and there's nothing rewarding about staying in treatment. And they tend to, these are the people who show up with a huge squamous cell tumor hanging off their penis and say, yeah, I don't, it's not been there very long. You know, it's been there a long time. They tend to live mostly in the now, and they're not consequence averse. They're more reward seeking. So stuff that feels good now tends to divert them from their long-term thing. And that's a thing that you can get at with cognitive behavioral therapy and talking to patients and developing a relationship with them. For instance, those patients, extroverted patients, are very dependent on physician approval. They like you to approve of them. They like you to call them a good patient. It really matters to them. And that can be a powerful persuader for patients to get sober and take their medicines and come to clinic. I say to patients all the time, you know, I miss you when you don't come to clinic. And I can see that really affects them. And I say, you know, I'm so proud of you. You've made 4 out of your last 5 appointments. And that's really impressive for you. If I gave you an 80, David, you'd be mad at me. And 80% isn't good enough for you. But for my patients, the HIV clinic, 80% may be the highest grade they've gotten in a long time on anything. So, you want to reinforce the behavior you want to see. I mean, you have to want to know what reinforcers are salient. Sometimes approval, sometimes getting family involved, telling family members that they're not going to show up for their appointment. You have to help them. Those kinds of things can be powerfully helpful.
Thanks, Glenn. We're going to do one more quick one, and then I think we'll conclude. This is from an anonymous attendee. Do you have any suggestions for prevention?
Prevention of depression and prevention of bladder cancer.
Let's say prevention of depression for today. Yeah.
Okay, good. So we know that things that reduce your risk of depression are stress, low stress states. So a healthy lifestyle, exercise. I think having a good diet helps reduce your risk of developing major depression. I think being physically active. I think having good day-night sleep cycle and good sleep hygiene reduces your risk. Exercise. I think that it's possible that there is a role for depression in folate and other B vitamins, and I very much encourage people to make sure that they have adequate vitamin intake, which again means a healthy diet. But other than that, I think that since it's a modest percentage of people who develop cancer, I wouldn't prophylax people. This was a big question in the HIV world. A third of patients are going to develop major depression. Do you prophylax everybody with antidepressants? And I don't advocate that, because even though antidepressants have a relatively low rate of morbidity, they do cause side effects in lots of people, and you don't want people tolerating those side effects unless they need to. On the other hand, if 80% of the people in the family have major depression and they come in with bladder cancer, I say, you know what? It's part of your regimen. You're going to get mirtazapine, because it'll help you sleep and it'll help you keep your weight up while we go through treatment. It'll decrease your nausea. It's good for nausea. I didn't mention this. There's a drug called olanzapine, Zyprexa, and it's underutilized as an antidepressant augmentation. It's also a great drug for nausea. We tend not to use it enough.
Excellent. Well, I would reinforce that suggestion that people get good sleep, eat well, and exercise. And again, reminder, Beacon Walk is coming up. Glenn, thanks a lot for a fantastic presentation. Thanks all of you for joining us. And we'll see all of you next month.
David, if anybody wants my slides, they're welcome to them.
Excellent. Thank you.
You're welcome. All right, everybody. Thank you so much for inviting me.